Drugs that increase lipoprotein removal. Bile acid sequestrants. Bile acid sequestrants increase conversion of cholesterol to bile acids in the liver and decrease hepatic cholesterol. The primary effect is a decrease in total cholesterol and LDL levels. These drugs have been associated with side effects related to taste and a variety of upper and lower GI symptoms. These include belching, heartburn, nausea, abdominal pain, and constipation. Bile acid sequestrants decrease absorption of many other drugs, e.g., warfarin, thiazides, thyroid hormones, beta blockers. Separating the time of giving these drugs from that of other drugs by at least 2 hours decreases this adverse effect. Proprotein convertase, subtilisin kexin-9 inhibitors. PCSK9 inhibitors are a newer class of cholesterol-lowering drugs. PCSK9 reduces the number of receptors on the liver that remove LDL cholesterol from the blood. By blocking PCSK9's ability to do work, more receptors are available and can get rid of LDL, thus decreasing circulating LDL levels. Evolocumab, Repatha, and alirocumab, Praluent, are two PCSK9 inhibitors. They are given subcutaneously every 2 weeks. Evolocumab may be given every 4 weeks at a higher dose, depending on patient preference. They are not a first-line therapy. They are used in addition to diet and maximum statin therapy for adults, familial hypercholesterolemia, and for patients intolerant of statin drugs. They also can be used for patients with CAD who need added LDL lowering because of inadequate treatment with statins. Drugs that decrease cholesterol absorption. Ezetimibe, Zetia, selectively inhibits the absorption of dietary and biliary cholesterol across the intestinal wall. Serves as an adjunct to dietary changes, especially for patients with primary hypercholesterolemia. When it is combined with a statin, either as a combination drug or as two separate drugs, even greater reductions in LDL occur. Antiplatelet therapy. Low-dose aspirin, 81 milligrams, is recommended for people who have CAD. For people at risk without known CAD, low-dose aspirin is recommended for adults 50 to 59 years old who have a calculated 10-year CVD risk of 10% or more, are not at increased risk for bleeding, e.g. history of GI bleeding, have a life expectancy of at least 10 years, and are willing to take low-dose aspirin for at least 10 years. For adults 60 to 69 years old who have a calculated 10-year CVD risk of 10% or more, the decision to take low-dose aspirin is an individual one made in conjunction with the HCP. Adults who have no contraindications, e.g. history of bleeding, have a life expectancy of at least 10 years, and are willing to take low-dose aspirin daily for at least 10 years, are more likely to benefit. Currently, there is not enough evidence to recommend low-dose aspirin for primary prevention in those younger than 50 or older than 70. Clopidogrel Plavix is an option for people who are aspirin intolerant. Gerontologic considerations, coronary artery disease. The incidence of heart disease greatly increased in older adults and the leading cause of death in older persons. In the older adult, CAD is often a result of the complex interaction of non-modifiable risk factors, e.g. age, and lifelong modifiable risk behaviors, e.g. inactivity, tobacco use. Strategies to reduce CAD risk and to treat CAD are effective in this age group. Aggressive treatment of hypertension and hyperlipidemia helps stabilize plaques in the coronary arteries. Tobacco cessation helps to decrease the risk for CAD at any age. Similarly, encourage the older patient to consider a planned program of physical activity. Physical activity improves activity performance, endurance, and ability to tolerate stress. Positive psychologic benefits can include increased self-esteem, emotional well-being, and improved body image. For the older adult who is obese, making modest dietary changes and slowly increasing physical activity, e.g., walking, results in more positive benefits than aiming for a significant weight loss. When planning a physical activity program, recommend 1. Longer warm-up periods, 2. Longer periods of low-level activity, and/or 3. Longer rest periods between sessions. Heat intolerance results from a decreased ability to sweat efficiently. Teach the patient to avoid physical activity in temperature extremes and to maintain a moderate pace. The older adult should exercise a minimum of 30 minutes on most days of the week as able. Encouraging the older patient to adopt a healthy lifestyle may increase the quality of life and reduce the risk for CAD and fatal heart events. Older adults face many of the same challenges as younger persons when it comes to making lifestyle changes. Older adults are more likely to consider change either 1. When hospitalized, or 2. When symptoms, e.g. chest pain, are the result of CAD and not normal aging. First, assess for the readiness to change and health literacy. Then, help the patient select the lifestyle changes most likely to produce greatest reduction in risk for CAD. Chronic stable angina. CAD is a chronic and progressive disease. Patients may be asymptomatic for many years but may eventually develop chronic stable chest pain. When the demand for myocardial O2 exceeds the ability of the coronary arteries to supply the heart with O2, myocardial ischemia occurs. Angina, or chest pain, is the clinical manifestation of myocardial ischemia. It's caused by either an increased demand for O2 or a decreased supply of O2. The most common reason for angina to develop is significant narrowing of one or more coronary arteries by atherosclerosis. This leads to insufficient blood flow to the heart muscle. For ischemia to occur from an atherosclerotic plaque, the artery is usually blocked, stenosed, 70% or more, 50% or more for the left main coronary artery. Chronic stable angina refers to chest pain that occurs intermittently over a long period of time with a similar pattern of onset, duration, and intensity of symptoms. It is often provoked by physical exertion, stress, or emotional upset. It is important to get an accurate assessment of the angina symptoms. When asked, some patients may deny feeling pain, but describe a pressure, heaviness, or discomfort in the chest. This discomfort is often described as a squeezing, heavy, tight, or suffocating sensation. It may be associated with other symptoms such as dyspnea or fatigue. Chronic angina pain usually does not change with position or breathing. Although most angina pain occurs substernally, it may radiate to other locations, including the jaw, neck, shoulders, and/or arms. Many people with angina describe a feeling of indigestion or a burning sensation in the epigastric region. The sensation may be felt between the shoulder blades. Often, people who describe pain between the shoulder blades or indigestion type pain dismiss it as not being heart-related. Some patients, especially women and older adults, report atypical symptoms of angina, including dyspnea, nausea, mid-epigastric discomfort, and/or fatigue. We refer to this as an angina equivalent. The pain of chronic stable angina usually lasts for only a few minutes. It often subsides when the precipitating factor is resolved, e.g. by resting, calming down, using sublingual nitroglycerin. Pain at rest is unusual and may indicate UA with ischemia. The 12-lead ECG often shows ST segment depression and/or T-wave inversion. These changes represent inadequate supply of blood and O2 to the heart muscle. ST depression is significant if it is at least 1 millimeter, one small box, below the isoelectric line in at least 2 contiguous leads. In a normal heart, the isoelectric line should be flat. The ECG changes return to baseline when adequate blood flow is restored and pain is relieved. Chronic stable angina is controlled with drugs on an outpatient basis. Because chronic stable angina is often predictable, drugs are timed to provide peak effects during the time of day when angina is likely to occur. For example, if angina occurs when rising, the patient can take medication as soon as awakening and wait 30 minutes to 1 hour before engaging in activity. A comparison of the major types of angina is outlined in Table 33.10. Silent ischemia refers to ischemia that occurs in the absence of any subjective symptoms. Patients with diabetes have an increased prevalence of silent ischemia. This is likely due to diabetic neuropathy affecting the nerves that innervate the cardiovascular system. When patients are monitored and silent ischemia occurs, ECG changes are revealed, e.g. ST depression and/or T-wave inversion. Ischemia with pain or without pain has the same prognosis. Prinzmetal's angina. Prinzmetal's angina, variant angina, is a rare form of angina that often occurs at rest and not with increased physical demand. It is sometimes seen in patients with a history of migraine headaches, Raynaud's phenomenon, and heavy smoking. It is usually due to spasm of a major coronary artery. Strong contraction, spasm of smooth muscle in the coronary artery results from increased intracellular calcium. Spasm may occur in the presence or absence of CAD. Factors contributing to coronary artery spasm include increased levels of certain substances, e.g. alcohol, cocaine, exposure to medications that narrow blood vessels, e.g. sumatriptan, Imitrex, or cold weather exposure. When spasm occurs, the patient has angina and transient ST segment elevation, not usually associated with an MI. The pain may occur during rapid eye movement, REM, sleep, when myocardial O2 consumption increases between midnight and early morning, or at rest. The pain may be relieved by moderate exercise with SLNTG, or it may disappear spontaneously. Cyclic short bursts of pain at the same time each day may occur with this type of angina. Calcium channel blockers and/or nitrates are an option. Stopping the use of any offending substances is recommended. Microvascular angina. In microvascular angina, chest pain occurs in the absence of significant CAD or coronary spasm of a major coronary artery. In these patients, chest pain is related to myocardial ischemia associated with atherosclerosis or spasm of the small distal branch vessels of the coronary microcirculation. This is known as coronary microvascular disease, MVD. MVD is often used interchangeably with the term syndrome X. It is more common in women. Often the angina is prolonged and brought on by physical exertion. These patients usually have positive stress test results and an inconsistent response to nitrates. Prevention and treatment of coronary MVD follow the same recommendations as for CAD. Interprofessional and nursing care, chronic stable angina. Chronic stable angina can progress or develop into UA or ACS. Therefore, any changes in the usual pattern of angina should be evaluated. A patient with chronic stable angina may be admitted with a change in the angina pattern. Until an assessment and diagnostic studies are completed, it may be unclear if the patient is having typical chronic stable angina UA or an MI. The goal of treatment for a patient admitted with angina is to decrease O2 demand and/or increase O2 supply. Nursing care focuses on the priority problems of managing acute pain and anxiety while increasing O2 delivery to the myocardium. The overall goals for a patient who presents with angina include 1. Relief of pain, 2. Immediate and appropriate treatment, 3. Preservation of heart muscle if an MI is suspected, 4. Effective coping with illness-associated anxiety, 5. Participation in a rehabilitation plan, and 6. Reduction of risk factors. Acute care. If your patient has angina, perform the following measures. 1. Position patient upright unless contraindicated and apply supplemental O2. 2. Assess vital signs. 3. Place patient on continuous ECG monitor. 4. Obtain a 12-lead ECG. 5. Provide prompt pain relief. First with NTG, followed by an IV opioid analgesic if needed. 6. Obtain cardiac biomarkers. 7. Assess heart and breath sounds. And 8. Obtain a chest x-ray. The patient may be anxious and may have pale, cool, clammy skin. The BP and HR may be high. Auscultation of the heart may reveal an atrial, S4, or a ventricular, S3, gallop. A new systolic murmur heard during an angina attack may indicate ischemia of a papillary muscle of the mitral valve, causing mitral regurgitation. The mitral valve does not close properly. The murmur may be transient and disappear when symptoms resolve. Ask the patient to describe the pain and to rate it on a scale of 0 to 10 before and after treatment to evaluate the effectiveness of the interventions. It is important to use the same words the patient uses to describe the symptoms, e.g. tightness, pressure. Assess for other signs of pain such as restlessness, ECG changes, high HR, respiratory rate, or BP, clutching of the bed linens, or other nonverbal cues. Support and reassure the patient. Use a calm approach to help reduce the patient's anxiety during an angina attack. If the chest pain is not related to an ACS, the patient may be discharged within 1 or 2 days. Further testing may be done during the hospitalization or as an outpatient. Patient teaching. Reassure the patient with a history of angina that a long, active life is possible. Preventing angina, or at least reducing the frequency of angina, is key. So teaching is important. Emphasize the importance of risk factor modification to slow the progress of CAD. Give the patient information about CAD, angina, precipitating factors for angina, and medications to treat angina. You can provide patient teaching in a variety of ways. One-on-one contact between you and the patient is often the most effective approach. Time spent providing daily care, e.g., giving drugs, offers many teachable moments. Teaching aids, such as DVDs, heart models, and printed information, are important resources for patient and caregiver teaching. Help the patient to identify factors that precipitate angina. Tell the patient how to avoid or control these factors. For example, teach the patient to avoid exposure to extremes of weather and eating large, heavy meals. Tell the patient to rest for 1 to 2 hours after a heavy meal because blood shifts to the GI tract to aid digestion and absorption. Help the patient to identify personal risk factors for CAD and ways to reduce modifiable risk factors. Teach the patient and caregiver about diets low in salt and saturated fats. Maintaining ideal body weight is important in controlling angina as excess weight increases the heart's workload. It is important that the patient has a regular, individualized program of physical activity that conditions rather than stresses the heart. For example, tell patients that walking briskly on a flat surface at least 30 minutes a day, most days of the week, is recommended. If needed, arrange for counseling to assess the psychological adjustment of the patient and caregiver to the diagnosis of CAD and the resulting angina. Many patients feel a threat to identity, self-esteem, and the usual roles in society. These emotions are normal and real. Drug therapy. Drug therapy for chronic stable angina aims to reduce symptoms of and the risk for MI and death. The most chronic medications to optimize myocardial perfusion, chronic stable angina, include nitrates, ACE inhibitors, beta blockers, and calcium channel blockers. Aspirin, previously discussed, is given in the absence of contraindications. Short-acting nitrates. Short-acting nitrates are first-line therapy for an acute episode of angina. Nitrates produce their principal effects by the following mechanisms: dilating peripheral blood vessels. This results in decreased SVR, venous pooling, and decreased venous blood return to the heart, preload. Therefore, myocardial O2 demand is decreased because of the reduced cardiac workload. Dilating coronary arteries and collateral vessels. This may increase blood flow to the ischemic areas of the heart. However, when the coronary arteries are severely atherosclerotic, coronary dilation is hard to achieve. Sublingual nitro. SLNTG tablets or translingual spray usually relieves pain in about 5 minutes and lasts about 30 to 40 minutes. The recommended dose of NTG is 1 tablet taken sublingually or 1 to 2 metered sprays on or under the tongue for symptoms of angina. If symptoms are unchanged or worse after 5 minutes, the patient should repeat NTG every 5 minutes for a maximum of 3 doses. Teach the patient to contact the emergency response system if symptoms have not resolved completely after 3 doses. Teach the patient the proper storage and use of NTG. It should be always easily accessible to the patient. Store the tablets away from light and heat sources, including body heat, to protect them from degradation. Tablets are packed in light-resistant bottles with metal caps. Once opened, the tablets lose potency. They should be replaced every 6 months. Tell the patient to sit down and place the NTG tablet under the tongue and allow it to dissolve. If using the spray, the patient should direct it on or under the tongue, not inhale it. SLNTG tablets should cause a tingling sensation when taken. Otherwise, it may be outdated. Warn the patient that a headache, dizziness, or flushing may occur. Caution the patient to change position slowly after NTG use because orthostatic hypotension may occur. Teach the patient and caregiver the proper use of NTG. Patients can use NTG prophylactically before starting an activity that is known to cause angina, e.g., emotionally stressful situation, sexual intercourse. In these cases, the patient can take a tablet or spray 5 to 10 minutes before beginning the activity. Tell the patient to report any changes in the usual pattern of pain, such as increasing frequency, nighttime angina, or angina at rest. Long-acting nitrates. Oral nitrates, such as isosorbide dinitrate, e.g., Isordil, and isosorbide mononitrate, are longer acting than SL or translingual NTG. They are used to reduce the frequency of angina attacks and to treat Prinzmetal's angina. The main side effect is headache from the dilation of cerebral blood vessels. Tell patients to take Tylenol to relieve the headache. Over time, the headaches may decrease, but the anti-anginal effects are still present. Orthostatic hypotension is a complication of all nitrates. Monitor BP after the first dose, since the venous dilation that occurs may cause a drop in BP, especially in volume-depleted patients. Finally, tolerance to long-acting NTG can develop. To limit this, patients may have a scheduled 10 to 14-hour nitrate-free period every day. Remind patients that taking a long-acting NTG preparation should not keep them from using translingual or SL NTG if chest pain develops. Nitro ointment. Nitro paste is a 2% NTG topical ointment dosed by the inch. It is placed on the upper body or arm over a flat muscular area that is free of hair and scars. Once absorbed, it prevents angina for 3 to 6 hours. The ointment should be wiped off each evening to allow for a 10 to 14-hour nitrate-free interval to prevent nitrate tolerance. Transdermal controlled release nitrates. Currently, 2 systems are available for transdermal NTG drug delivery: silicone gel and polymer matrix. These systems allow timed release of NTG over a 24-hour period. These preparations may be removed in the evening to allow for 10 to 14 nitrate-free interval to reduce risk for NTG tolerance. ACE inhibitors and angiotensin receptor blockers, ARBs. Patients with chronic stable angina who have an ejection fraction EF of 40% or less, diabetes, hypertension, or CKD should take an ACE inhibitor, e.g. lisinopril, Zestril, indefinitely, unless contraindicated. Patients with chronic stable angina and a normal EF, diabetes, and one other CAD risk factor should also take an ACE inhibitor to decrease the risk for MI, stroke, and death. These drugs result in vasodilation and reduce blood volume. Most important, it can prevent or reverse ventricular remodeling in patients who have had an MI. For patients who are intolerant to ACE inhibitors, e.g. cough, angioedema, angiotensin receptor blockers, ARBs, e.g. losartan, Cozar, are used. Beta blockers. Beta blockers are given for relief of angina symptoms in patients with chronic stable angina. Patients who have LV dysfunction or elevated BP or had an MI should start and continue beta blockers indefinitely, unless contraindicated. These drugs decrease myocardial contractility, heart rate, SVR, and BP, all of which reduce the myocardial O2 demand and relieve angina symptoms. Beta blockers that reduce the risk for death in patients with LV dysfunction, HF, or MI include carvedilol, Coreg, metoprolol, Toprol XL, and bisoprolol. Beta-1 receptors are found in the heart. Beta-2 receptors are found in blood vessels, lungs, and liver. Some beta blockers are called cardioselective beta blockers because they only block beta-1 receptors, e.g. atenolol, Tenormin, metoprolol, Lopressor. Some beta blockers, referred to as non-selective beta blockers, block both beta 1 and beta 2 receptors, e.g., nadolol, Corguard, propranolol, Inderal. Some beta blockers block alpha 1, beta 1, and beta 2 receptors, e.g., carvedilol, Coreg, labetalol, Trandate. Beta blockers have many side effects that can be poorly tolerated. These include bradycardia, hypotension, wheezing from bronchospasm, and GI effects. Many patients report weight gain, depression, fatigue, and sexual dysfunction. Absolute contraindications to using beta blockers include severe bradycardia and acute decompensated HF. Patients with asthma should avoid beta blockers, especially non-selective ones. They are used cautiously in patients with diabetes since they mask signs of hypoglycemia. Beta blockers should not be stopped abruptly without medical supervision, as this may result in an increase in the number and intensity of angina attacks. Calcium channel blockers. If beta blockers are contraindicated, are poorly tolerated, or do not control anginal symptoms, calcium channel blockers are used. Their main effects are 1. Systemic vasodilation with decreased SVR, 2. Decreased myocardial contractility, 3. Coronary vasodilation, and 4. Decreased HR. They are used to treat Prinzmetal's angina. There are two groups of calcium channel blockers. The dihydropyridines, e.g. amlodipine, Norvasc, nifedipine, Procardia, have more vasodilatory effects. The non-dihydropyridines, e.g. verapamil, Calan, diltiazem, Cardizem, have a greater effect on decreasing HR and contractility. Side effects include fatigue, headaches, dizziness, flushing, and peripheral edema. The non-dihydropyridines enhance the action of digoxin by increasing serum digoxin levels. Digoxin levels are closely monitored after starting these agents. Teach the patient the signs and symptoms of digoxin toxicity. Verapamil can cause severe constipation by relaxing GI smooth muscle and slowing peristalsis, especially in older adults. Lipid-lowering drugs. A moderate or high dose of a lipid-lowering drug is given unless contraindicated. Patients with chronic stable angina are encouraged to follow a diet low in saturated fat and cholesterol. Sodium current inhibitor. Ranolazine, Ranexa, a sodium current inhibitor, is used to treat chronic angina in patients who have not had an adequate response with other anti-anginal medications. Although it is approved as a first-line agent, it is usually added to the medication regimen only when the angina is not well controlled. Ranolazine does not affect the BP or HR, but it can prolong the QT interval. Use it very cautiously in patients with a long QT interval, or who are taking other QT prolonging drugs, e.g. fluoxetine, Prozac. Common side effects include dizziness, nausea, constipation, and headache. Diagnostic studies. When a patient describes new onset chest pain and CAD is suspected, or when a patient with chronic stable angina has a change in the angina pattern, a variety of studies are done. After a detailed health history and physical examination, a 12-lead ECG is done and compared with a previous ECG to look for changes that may indicate an ACS. Laboratory tests, e.g. cardiac biomarkers, are used to determine if the patient is experiencing an ACS. Other laboratory tests may be done, e.g. lipid profile, CRP, to identify risk factors for CAD. A chest X-ray is done to look for cardiac enlargement, aortic calcifications, and pulmonary congestion. An echocardiogram can detect resting LV wall motion abnormalities, which may suggest CAD. If the ECG and cardiac biomarkers are negative, an exercise stress test with or without echocardiography or nuclear imaging may be done either during the hospitalization or as an outpatient. For patients with physical limitations in walking, a pharmacologic adenosine or dipyrimidine stress test with nuclear imaging or a pharmacologic dobutamine stress echocardiogram are options. Stress testing usually does not detect coronary blockages less than 70%. Besides stress testing, other tests may be done if the ECG and cardiac markers are negative. Electron beam computed tomography, EBCT, or coronary computed tomography angiography, CCTA or CTA, testing may be done if there is no evidence of an ACS and the patient remains free of chest pain. Cardiac catheterization. For patients with increasing angina symptoms, a cardiac catheterization is the gold standard test to identify and localize CAD. It is also recommended if the ECG shows ST to T wave changes, not ST elevation, and or cardiac biomarkers are positive. This procedure should be done only if the patient is a candidate for percutaneous or surgical coronary revascularization. If a coronary blockage is amenable to treatment, coronary revascularization with percutaneous coronary intervention (PCI) may be recommended. PCI may be done at the same time as the cardiac cath. During PCI, a catheter with a deflated balloon tip is inserted into the blocked coronary artery. The deflated balloon is positioned inside the blockage and inflated. This compresses the plaque against the artery wall, resulting in vessel dilation and a larger vessel diameter. This procedure is called balloon angioplasty. Intracoronary stents are usually placed after a balloon angioplasty. A stent is an expandable mesh-like structure designed to keep the vessel open. It provides support to the arterial wall. There are two types of stents: bare metal (BMS) and drug-eluting (DES). A DES is coated with a drug, e.g. everolimus, zotolimus, to reduce the risk for overgrowth of the intimal lining, neointimal hyperplasia, within the stent. This is the primary cause of in-stent restenosis, ISR. This risk is lower with the use of a DES. Because stents are thrombogenic, drugs are used to prevent platelet aggregation within the stent and acute stent thrombosis. Drugs commonly used during PCI are unfractioned heparin, UH, or low molecular weight heparin, LMWH, a direct thrombin inhibitor, e.g. bivalvuridine Angiomax, and or a glycoprotein 2B/3A inhibitor, e.g. eptifibatide integralin. After PCI, the patient receives dual antiplatelet therapy, DAPT, e.g. aspirin indefinitely, and ticagrelor or clopidogrel Plavix until the intimal lining grows over the stent and provides a smooth vascular surface.